So before I get started, I want to ask Dr. Tyler one thing. A question was raised, can everybody access all of the presentations or their slides through a website? And then I just want to clarify one other point. Yesterday when I mentioned that I, as a clinician, typically use this 1 year time frame, let me clarify. These are for patients who are greatly bothered. So let's use David's example yesterday that he shared with us. You know, his reaction to getting his tinnitus, the tinnitus stayed, perhaps there would have been, more emotion and a lot of fear and a lot of disruption to his life. And so those are the patients that when they come in, if we recommend extended counseling or extended care, what we typically see is we want to see them weekly for that first month. And then as long as we're going in the right direction, then we may go every 2 weeks for a while. And then we may go monthly. And for many people who find themselves in that real bothersome category, they may have to stop working for a while. Or they take a leave of absence. Their personal life is very disruptive. And so I'm not saying they all stay in therapy for a full year, but what I'm saying is sometimes having that time frame of a year can be relieving for people, and they can understand, okay, I'm going to sort this through and I'm going to learn how to live with this new situation. And next year at this time, I hopefully will be, and then they'll have their goals at this place, back to work, sleeping well, off of all medication, whatever their goal may be. So it helps them understand it's not a quick fix. Okay, I just want to clarify that. I have lots of slides and way too much to go over in 15 minutes, so just go back and review on your own, and you can always contact us if you have questions. Rich and I don't solicit feedback, but we do receive it, and the only reason I'm sharing this feedback with you is because I want you to see that if you're starting a new clinic or you're entering this field as a new clinician, the feedback we get and the thank yous we get are about the time that we've given to the patient, the way we understand or the knowledge base we have, the advice we give, how we articulate, and the fact that we introduce them to options. And I think this patient said it best. We created a safe place for someone who was very confused, and I'm hoping that's happening less and less over time. I would say at least 5 years ago, almost every patient we saw was so confused, but now I think we have more clinicians doing this, and so we have less patients just kind of fumbling through the system. But for those that still are, we provide, a safe place, a place to get started, a place to get them in the right direction. And we may be unique, and I hope we aren't always unique. So I hope we can change this around. We know now, after hearing all the talks yesterday, that we really have to listen and be patient and be sympathetic and such. But one of the things we have to really talk about and think about is we have to have the time. And so, I talked to a student just a little bit ago before this talk, and I realized we didn't discuss this. But if you're in private practice, you're going to see many, many patients with tinnitus who are not bothered. But how do you differentiate who goes through your standard care, and how do you catch the ones that are bothered before you start going in a direction that maybe you shouldn't go in? And so one of the things we talked about last year is having an intake form. And your intake form can be very simple. It can just simply say, do you have tinnitus, yes or no, which hopefully all of your forms have. But a secondary question can simply be, are you bothered by your tinnitus? Because my experience has been, when you're not bothered by your tinnitus, you're not bothered. So let's compare David's response to, is it Shirley in the back? When she was like, I have tinnitus, and they said, oh, there's nothing we can do about it. Okay, fine. She's not bothered. But when you are bothered, you're going to circle yes. 1,100,000 times, and you're going to write a paragraph around it. And when you're not bothered, you're going to zip by it. So when you're not bothered, you can just go on to standard clinical care. And when you do present as being bothered, maybe you pause right then and there in your clinic and think about shifting their care over to your tinnitus management-based portion, which you build in much more time, okay? Okay, we know our role is not to cure, but we're going to help the patient and they're going to become their own coach. We're going to verbalize this, it's going to be collaborative. It's okay that we don't have all the answers. We're going to share that we don't have all the answers, but we're going to help this person figure out what's going to work best for them. We know we're going to introduce additional support staff if needed. We're going to make referrals. We're going to help them find other local resources. I don't want to overlook this. I was duped many times in the beginning by this. Please take the time to address the psychology that was there prior to the tinnitus. If a patient has horrible sleep issues, but you find out they've always had sleep issues and they've had multiple sleep studies, then you may be limited in where you can go in that section. My experience has been patients are very easy to guide you and to say, Shelley, prior to tinnitus, I had none of these issues. Now all of a sudden I have all of these issues. Versus having to ask and needing to ask with someone who's very anxious, have you ever been diagnosed with an anxiety disorder? Yeah, actually I have generalized anxiety. I've had it since I was 13. Don't try to fix something that has already been in place, but just be aware that I feel that tinnitus magnifies whatever's there. So if you're a little anxious, sometimes after that initial onset, anxiety is high. If you're naturally a depressive type, you can really fall into a depression. If your marriage is a little rocky, I see marriages that go through some, big storms. So always be aware of what's already there. And we have some slides that help with that, okay? And you have to be able to have this conversation, okay? How would you describe yourself? And just start getting to know the person. Again, set goals. When you set goals, then you have a clear understanding of where you're going. We already talked about this, but I'll say it over and over and over again. Let's go back to David yesterday. He had no control. This thing came into his life. He's an audiologist. He still understands it, but it was very disruptive. What's the one thing he can control? He can start controlling his thoughts. It's not easy. I'm not saying he can do it quickly, but there's where you shift and start to feel some control, and that's when you really start to pinpoint on the thoughts and how they connect to your emotions, okay? So I'm going to really encourage you to consider having that aspect in your tinnitus counseling. How do you address negative thinking? We could spend a whole seminar on this. So take this slide and go look at it and kind of learn from it. I think testimonials are wonderful, but if I'm in a consultation room and it's just me and another patient, I don't know how to use those. So I have one that I love and I want to share with you guys, and I hope if you don't know about it, you do now and you'll use it. Dr. Stephen Dangler is an MD who, like David, developed tinnitus, and the onset was hard and fast, and it was very disruptive, and it did not go away. And he actually will tell you that he lost his practice because of his tinnitus. So he writes a letter to other fellow tinnitus sufferers, and it's a really powerful letter, and I use that. I hand it out at that first session, that introduction session, when the patient's feeling very alone, because I don't have tinnitus. I can tell them I don't, but I know this gentleman, he's real. He used to come to our conferences and present, and here's his story, and he has advice for you. And this is a great place to start. Again, I encourage you to look at what is available for cognitive behavior therapy. You don't have to become a therapist. One of the things that I like to do is, with the help of a patient, is identify, remember we have negative, positive, and neutral thoughts, how we think negatively, because believe it or not, there are 12 common styles. And there is one book that Rich and I really appreciate, and this author has hooked some of these cognitive behavior-like techniques with tinnitus. And so you can actually go through these to try to understand the patterns. So when someone is falling into one of those negative styles, they can start to think about, is this how I typically do this? And what happens in my real life when I start to do this? And to start to make some changes. The ABCD model is not that overwhelming. Take a look at it. You can do it. A is simply the situation. B is the thought. We already talked about this yesterday. C is what emotion hooks to that. And then D, how do I stop it? What are my choices? Am I going to disrupt it? Am I going to challenge it? Am I going to replace it? And when I do that, then what's the new emotion that surfaces? And how did that process feel? This is the book that we recommend, and of course this is the second book that we find extremely helpful. And again, all of these are in my slides. Beverly Thorne has a really good book called Cognitive Therapy for Chronic Pain, and I recommend you take a look at this as well. She has an interesting approach. She says pain is stressful, but stress attacks us in 3 ways: cognitively, emotionally, and physically. So if tinnitus is doing that to us, let's not focus on the tinnitus, but let's pick one of those 3 to focus on. What is it doing to you physically? Well, let's focus on that. What is it doing to you emotionally and cognitively? So now the focus is not on the tinnitus, but on how our body is reacting and what can we do differently there. We talked a little bit about this yesterday. How do you approach stress? Are you the type of person that feels stress is a threat, which leads to avoidance and anxiety? Do you see it as a challenge, which empowers you? Do you see it as a loss, and do you get really sad? Okay. All right, so 3 areas that I have seen where I have hit roadblocks with a patient, and I can't go through all this, but my slides are in there. One roadblock is patients who come in, they're there because they want help, but they don't want to open up yet. They don't want to acknowledge it. They don't want to talk about it. And you can almost see it in their physiology. They're real guarded. And then you have folks who want to track their tinnitus, and they want to tell you on a day-by-day basis what it's doing, and they want to figure out why. And for those 2 types of patients, I've got some techniques and tools that I've used, but if I can't get them past that, we really don't get anywhere. So you may spend your first 4 sessions repeating the same stuff because that's where they're at, and you can't move past that. Of course, controlling the thoughts and emotions is a huge section. That's a section all on its own. So these are some of my tips and thoughts and things that you can do with some of these patients, okay? And we clearly don't have the time to go through this. When you have a patient who's really stuck with their thoughts and their emotions, I find that it's just 2 different categories. Folks who ruminate, and they keep going back over, why did it happen? Why did it happen? I wish I hadn't. I wish I hadn't. I forget what your phrase was. If only, if only, if only. And then you have the worriers, and they're thinking of what's coming down the pike. What's next? What's next? What's next? And if you want to take some time to look at how to help with rumination and worry, regardless of tinnitus, there may be some tools and techniques you can use. And this is my new go-to book for me. It's What to do when you worry too much, and it's a children's guide. So I like it because as a clinician who's not a psychologist, who's not going to pretend to be, who's going to stay within her scope of practice, needs to understand worry in a simple manner. And are there tools in here I can use and adapt? So this is not in my slides, but this is by Dawn Huebner, Huebner. And I love it, so I think you guys should take a look at that one. Huebner, Huebner. Okay. And then I have some more information about rumination and worry in here. I think everybody needs basic relaxation tool techniques, either as a handout or as a visual or as a guide. And I do want you to know that Gerhard Anderson has in the book Tinnitus Treatment Clinical Protocols a 4-week relaxation approach, which is neat because you can use it with your patient and you can assign homework for week 1, 2, 3, 4. So I want to point that out to you. There is information in the literature on how a spouse can help a spouse with an illness. And I think if you look through some of that, you can better understand that dynamic. And Stephen Dangler's wife wrote a letter, Tinnitus Spouse Survival, tips and tools on how to be helpful without making things worse. So lastly, this is advice that we got from a patient who was in our program for that full year and who happened to be a ruminator. So we got stuck. We couldn't get past that point. We eventually did. And I asked him, when he was in a much better place, a year after coming into the clinic, when he was fully functioning and back to life and feeling really good, what helped? And he said, working with a tinnitus professional, because they understand what's going on, but be open to working with other professionals. Because for this person, we had to do that. Stop talking about your suffering with your friends and family. They love you, they want to help you, but they can't. So take all that emotion and lay it on your tinnitus professional and work with them to try to minimize some of those relationship pitfalls. That doesn't mean you don't share, and it doesn't mean the spouse isn't involved, but you have to be careful of how you use your spouse. Have faith that things will get better, which I would say have a mantra that will go with you to help you with that. And then no matter what the characteristics of your tinnitus, so no matter if it's going louder, softer, or it's intermittent, it's this, that, work on the controlling what you can, which is the internal, like Bev said yesterday, how you react to what you can't control. Are you going to fight it? And how long are you going to fight it? Or are you going to try to work with it? And how are you going to do that?